Dr. Veer Prakash, we are good to go.
Okay.
Thank you.
Distinguished speakers, moderator, colleagues, and dear participants, a very good afternoon to all of you. On behalf of JIBB Institute of Biotechnology and Bioengineering, Sam Higginbottom University of Agriculture, Technology and Sciences, Prayagraj, India, I, Professor Viru Prakash, Associate Dean, Administration, welcome you all to the online expert panel discussion entitled Triangulation of COVID-19 Perspectives from EU, USA, and India, organized by JIBB Institute of Biotechnology and Bioengineering. Before we start the proceedings, I would like to invite Reverend Dr. Samuel Richmond Saxena, University Chaplain, for invoking the blessing of Lord. Reverend Saxena.
Thank you, sir. Bible says, I will exalt you, my God, the King. I will praise your name forever and ever. Every day I will praise you and extol your name forever and ever. Great is the Lord and most worthy of praise. His greatness no one can fathom. Let us look our Lord in prayer. Heavenly Father, we are thankful and grateful to you for this wonderful opportunity you have given to Sam Higginbottom, University of Agriculture, Technology and Sciences, especially JIBB Institute of Biotechnology and Bioengineering, that they are able to organize this expert panel discussion related to COVID-19. We are thankful for the representations from different countries, Europe, USA, and India. We are thankful for especially the expertise who will be speaking here, the panelists. We pray that your blessing be upon them. And especially as we continue with this discussion related to COVID-19, we become hope for many people as the world is struggling with COVID-19. We pray and seek your blessing upon our university, upon our Honorable Vice Chancellor, and especially we pray for all our authorities. We pray for the Dean of JIBB Institute of Biotechnology, who's coordinating and moderating the whole program, and also our engineer Wesley, who is also helping in coordinating the whole system. Thank you, Lord. We pray that whatever is being discussed by our experts here will add blessing to all of us, and we may continue to praise your holy name, because you are a Lord and you are a creator and sustainer, and you protect us as we suffer through this COVID-19. We ask your divine intervention. In Jesus' name we pray. Amen.
Thank you, sir, for the prayer. We also have with us Joint Registrar of our university, Engineer John Wesley. I request him to briefly introduce the university. Engineer Wesley, sir.
Thank you, Dr. Veer Prakash. Respected panelists and my dear participants, Sam Higginbottom University of Agriculture, Technology and Sciences, SHUATS, earlier known as Allahabad Agriculture Institute, was established in the year 1910 under the leadership of Dr. Sam Higginbottom, an American scientist. The institution has completed more than 110 years now of dedicated and relentless service to the nation with the vision, gospel and power, and mission Feed the Hungry, Serve the Land. Under the dynamic leadership of our Honorable Vice Chancellor, Most Reverend Professor Rajendra Bilal, Allahabad Agriculture Institute was conferred the deemed to be university status by MHRD Government of India in the year 2000. It was later renamed during our centenary year in the year 2010. It was renamed as Sam Higginbottom Institute of Agriculture, Technology and Sciences, deemed to be university by MHRD Government of India. In the year 2016, after considering the adequate availability of teaching and non-teaching staff and other essential infrastructures, the Uttar Pradesh legislature decided and upgraded, reconstituted our deemed university as a full-fledged university under State Act. Hence, now we are Sam Higginbottom University of Agriculture, Technology and Sciences. SHUATS is a united endeavor of Christian community in India for promoting rural life and development in conformity with the Christian vision of humankind and the creation. The university is held in trust as a common ecumenical heritage by the Christian churches and Christian organizations of this country. We operate with Faculty of Agriculture, Engineering and Technology, Sciences, Business Studies, Theology, Animal Husbandry, Education, Film, Mass Communication, and Health Sciences. NAC, an autonomous body of UGC, accredited our university with A grade in the year 2013. And in 2014, MHRD placed us among the A-grade institutions of among the deemed universities. Currently, we have more than 13,000 students pursuing their higher studies on campus at SHUATS with more than 2,000 faculty members. These words, I welcome you all on behalf of the university and wish you all a wonderful experience throughout this panel discussion. Thank you.
Thank you, Engineer Wesley, for the introduction of the university. Now I request Professor Robina Lawrence, Associate in Academics, JIBB Institute of Biotechnology and Bioengineering, to introduce our institute.
Thank you, sir.
Professor
I
Lawrence.
extend a very warm greetings to all. This is my privilege to underline the expression and contributions of JIBB Institute of Biotechnology and Bioengineering at Sam Higginbotham University of Agriculture, Technology and Sciences, Prayagraj, in the gathering of global scientists, experts, academicians, and representatives of our society. The Institute facilitates a seamless transition from fundamental or basic sciences to exploitable technology and seeks to provide the faculty and student with opportunities to develop their creative insights and improve their analytical and professional skills. Comprising a vibrant community of faculty, students, and researchers, the Institute offers an ideal place to learn, teach, and conduct research, opening vistas to pursue careers that contribute globally in research, teaching, industry, entrepreneurship, etc. The Institute has well-established departments of molecular and cellular engineering, industrial microbiology, biochemistry and biochemical engineering, computational biology, and bioinformatics. The faculty of the Institute is highly qualified, skilled, and has more than adequate experience from various national and international prestigious universities. Our teaching expands from undergraduate to postgraduate and doctoral education using hands-on problem-solving approaches and cutting-edge technology. The courses offered by various departments of the Institute provide the undergraduate, postgraduate, and doctoral students the very best of theoretical knowledge and practical skills in disciplines of biotechnology, microbiology, computational biology, biochemistry, and biochemical engineering, backed up with well-equipped laboratories and experienced and motivated faculty. The departments operational in the Institute to their credit several international and national funded research projects, patents, and publications in journals of repute. Human resource development is the key area. Biotechnology is a priority of the Institute, and JIBB Institute of Biotechnology and Bioengineering now extends its reach to agriculture, food, pharmacology, medicine, tissue culture, biomedical engineering, nanoscience, forensic science, bioengineering, and molecular engineering. The Institute has an outstanding record of preparing students for diverse careers in academia, government, and industry. Our former students are currently involved as research professionals in biotechnology companies, both abroad and in India, and pursuing doctoral or master's program in foreign universities and prestigious Indian institutions. The JIBB Institute of Biotechnology and Bioengineering at SHUATS feels proud and privileged to host this prestigious expert panel discussion on triangulation of COVID-19, perspectives from European Union, USA, and India. Thank you. And now I request Professor Viruprakash to continue with the proceedings of the day.
Thank you very much, Professor Lawrence. Now I hand over to Professor I.R. Jonathan Elal, Dean, JIBB Institute of Biotechnology and Bioengineering, and Director, Innovation Projects and Consultancy, SHUATS, to moderate the session.
Thank you,
Professor Lal, sir.
Thank you, Professor Prakash. Very good afternoon to all the panelists, the experts, and all the participants. We have had over 1,400 registrations and people are coming in and we're pretty excited. This is sort of a very unique, one-of-a-kind webinar, because so far all the webinars we have been attending or organizing anywhere else, I saw also online across the world, most have been via lectures or conferences. This one is a bit unique in its own because it's the first of its kind, an expert panel discussion from experts across 3 continents. And we are pretty excited and pumped, and we hope you will enjoy as we go through. Before we start, let me introduce you to the panelists. The first panelist is Dr. Dennis Horgan. He is the Executive Director of the European Alliance for Personalized Medicine. He has a high, could you mute your videos? He has high impact policy and government affairs leaders with 15 plus experience, delivering policy and regulatory change to develop an environment for personalized healthcare in the EU. He is an entrepreneurial self-starter who established a political policy stakeholder association in Brussels that achieved policy, regulatory, funding, and government support to bring personalized medicine and diagnostics into healthcare systems. Proven leader with experience of driving change, talent, and performance in matrix multinational teams. Outside the EU, he has also worked in Mexico, Israel, Afghanistan, and Pakistan. He is the co-chief editor of the academic journal entitled Public Health Genomics with a good impact factor, and he has published over 40 academic publications. Welcome, Dennis, to this show. Our second speaker, second expert panelist is Professor Stefanie Bosia. She is full professor of hygiene, preventive medicine, and public health at UCSC in Rome. She obtained her master's in science and epidemiology and biostatistics and a PhD in genetic epidemiology from the Erasmus University Medical Center, Rotterdam. She is the director of the section of hygiene of the Department of Health Science and Public Health of USC and president of the Public Health Epidemiology section of the European Public Health Associations. From 2016 to 2018, she was an adjunct professor at the Mount Sinai Medical School, New York. In 2018, she founded the spin-off company, Value and Health Technology and Academy for Leadership and Innovation. She currently coordinates the project titled European Network Staff Exchange for Integrating Precision Health in the Healthcare Systems, funded by the European Commission within the Horizon 2020 Maria Curie projects. She is also a partner of multiple projects and funded grants from the European Commission. Welcome, Stefanie. Our next panelist is Dr. Sasmit Patra. He is the member of parliament from the Rajya Sabha. He is member of the Parliamentary Department Standing Committee on Human Resource Development, which covers the Ministry of HRD, Women and Child Development, Skill Development and Entrepreneurship, and Sports and Youth Affairs. He is the member of the Parliamentary Joint Committee on Office of Profit. He is also the youngest Rajya Sabha member from Odisha. He is the national spokesperson and media coordinator of his national party, Biju Janata Dal. He is the secretary and member of the State Council of Biju Janata Dal, as well as the member of the BJD's IT Wing Core Committee. He has a PhD, MBA, and LLB, so he's quite diverse. He has 17 years of work experience in academics, business research, industry, corporate sector, United Nations Development Program for the government of Odisha. And he was also the dean of the Xavier Business School and the first Indo-French business school in India, a joint collaboration between Xavier University and Employing Business School, France. Thank you, sir. Welcome to the program. Our next panelist is Professor Sarvas A. More. He is a distinguished scientist and a serial entrepreneur in the field of infectious disease diagnostics, human biomarkers. He graduated from VU University, Netherlands in biochemistry and molecular biology. His PhD was from the Department of Pathology on the epidemiology, transmission, national course, diagnosis, and immunopathogenesis of human urogenital chlamydia trachomatis infections. He also has a master's in biobusiness and entrepreneurship. He is currently the head of the Laboratory of Immunogenetics, Department of Microbiology and Infection Control, Free University Medical Center, Amsterdam, the Netherlands. He is also the director of the Institute for Public Health Genomics, which is located in the Department of Genetics and Cell Biology, Maastricht University, Netherlands. He is also the professor of host pathogen genomics and public health. He is the coordinator of Dutch Chlamydia Trachomatis Reference Laboratory and co-founder and co-director of several spin-in companies and spin-off companies in the Netherlands. We welcome you, sir. Thank you for coming. Next is Ms. Rachel England. She is the Director of Product Strategy and Implementation, Tech Mahindra Health and Life Sciences USA. So she has an Indian connection. She's a seasoned healthcare consultant, 10 plus years of experience partnering with health systems nationwide to improve care delivery processes, patient experience, and financial outcomes. Particularly passionate about technology and data-driven value-based care initiatives, care management, process workflow improvement, and achieving strategy business objectives by alignment with optimization of the revenue cycle functions. Welcome, ma'am. So this is the list of panelists, and another connection which I did not mention was that my own connection with all the panelists. For example, Professor Sarvas More was my boss in the Netherlands when I was working there. During working with him, I collaborated with Dr. Dennis Horgan, who is the Executive Vice President of the European Alliance for Personalized Medicine. And during that time, me and Ms. Rachel England, we met at several conferences, and that's where we got business networked. And during my work with Sarvas, I collaborated on the Public Health Genomics European Network Program with Professor Stefanie. And that's how the common theme and how we come together. Now, And of course, Dr. Patra, he is also a former alumni of our university. He was a professor here at the business school, and we welcome you, sir. It's nice to see you after a long time. So, dear participants, the panel discussion will be as such. There will be three sections. The first section will be that general questions will be asked to the panelists, taking their views from their countries of residence. Then the second section round of questions will be specific questions focused on their specialty. And then the third section will be questions from the audience, that is you. So if the audience, while listening to them, have any questions, you can put it in the Q&A section at the bottom of your screen of the Zoom app. So at the Zoom app at the bottom, you see the Q&A questions. Our associate deans will select those questions, hand it over to me, and based on the amount of time, we may ask those questions. So welcome and thank you very much. So now we're going to start this unique webinar panel discussion. Is that what we have here? We have a combination of scientists, politicians, policymakers, healthcare professionals, and business experts. So it is quite diverse, and there is a plethora of questions we want to ask, and we are curious because, as the title says, Triangulation of COVID-19, perspectives from the EU, USA, and India. We want to see how these different countries are doing. So, of course, as of now, according to the Worldometer, the total amount of corona cases worldwide is 15,380,140 cases, and total deaths is 630,343, and total recovered is 9,355,528 as of today. So now I first would like to go to Italy. I'd like to go to Stefania. In Italy, we have a total amount of coronavirus cases of 245,032. Deaths 35,082, and recovered 197,628. Now, why we start with Italy is that when China started in 2019, this pandemic, this panic which started there, the attention shifted towards Italy. Then Italy had become the epicenter in the EU in a time when the attention was diverted from China. Of all the EU countries, why or how did Italy become an epicenter? Over to you, Stefanie.
Thank you, Jonathan, and good afternoon, everyone. Thank you for organizing this panel discussion. So in answering the question, I take a step back and trying to remember what was happening at the end of January. At the end of January, on the 31st, the WHO declared that the virus was a global health risk. And at that time, actually, a couple of weeks before, in Rome, which is based, in the center of Italy, we had already 2 Chinese tourists hospitalized for COVID-19. And since well before the end of January, Italy was the first European countries to stop direct flights from China, actually. And at the end of January, on January 31st, Italy declared a national emergency for COVID-19. But we had to wait 3 weeks on the 21st of February to detect the first case in Italy that has been detected in Lombardy, that actually was the epicenter of the pandemic in Italy, reporting more than 39% of overall cases so far. A paper actually reported on the phylogenetic analysis of the strain had revealed that those in Lombardy were not directly coming from China, but they were coming from Germany. In fact, Lombardy is a highly industrialized region with strong connection with Germany for the manufacturing activity. So you might know that Italy has 60 million inhabitants, and it is the second oldest country in the world, with around 22% population older than 65 years old. So this partly explains also the high mortality rate, the case fatality rate reported in Italy, which is around 14%. And in Italy, also 40% of the population have at least one comorbidity. If we make a comparison with UK, this proportion is actually half, 20% as one comorbidity. So you can understand that the structural population contributed also to the increased susceptibility, but also high mortality and case fatality rate. However, some additional reasons can certainly explain why Italy has been hit so hard and with such high death rate, because it was certainly the first in European Union, so definitely unprepared in terms of equipment, medical equipment. Also, Italy has a decentralized health system, so largely underfinanced in the past 10 years. with the 21 different and autonomous regional health systems. So it's not one unique health system. However, after the first week of the epidemics, the Prime Minister of Health took back the powers from the regions to handle the situation. Also, we had some bad luck. We can admit that we had a soccer match in Bergamo, which was the one municipality experiencing an incredible excess death rate, 500% excess death rate in March. And there was a match, Atalanta-Valencia, a soccer European match that has been placed the day before the first case has been detected. So actually on that day, no one could predict the extent and the risk of population participating as attendance of the match actually. And also Lombardy has an hospital-centered approach, while other regions in Italy, like Veneto, use more a community-based approach with limited hospitalization and diffuse testing. And lastly, also Italy has a limited ICU capacity, like 4 per 100,000 inhabitants, while in the United States we have 10 times higher capacity or 5 times higher in other European countries. So in a nutshell, this can be an explanation.
Okay. Then further on, the tragic stories we have all heard that was going on in Italy. How was Italy able to overcome that death rate? Was it aggressive testing part of the strategy? Because initially you were all up in the news, and then suddenly, slowly it went down. How did you do it?
Well, testing increased day by day, so reaching an average of 18,000 tests per day, although it was very uneven distributed across regions. Italy was certainly very brave with respect to, because it was the first one experiencing such situation in the European Union. And in the coming weeks after the first case has been detected, local, regional, red zones were created, schools were closed. Finally, national lockdown was in place on March 8th. And on March 11th, basically all manufacturing system closed for a month. And lockdown was certainly progressively released from May the 3rd, where restriction also from traveling outside of the regions, and from May 18, all the rest of the activities open, including restaurants. However, we can say that the normality, the situation came back only from the June the 3rd. However, schools are not open yet in Italy. They will be opening at the beginning of September. We have strong fines applied for bars, restaurants that do not force people to wear masks. So masks are compulsory in all closed public settings since the beginning of the restore of all the activities, and also at workplace. And 50% of workplace activity are now done remotely. And in some regions, it is still compulsory to wear mask in open air settings. This has actually been, probably will be restored only in a couple of weeks. So we can say that overall there was quite a strong leadership in make this situation being, let's say, in making the curve being flattened.
Okay. One final question from the journalist side, apart from me. What could have been done differently according to you, based on your experience, how you observed how it went? What could have been done differently?
Yeah, this is a difficult question. We can say that every country public health service were definitely overwhelmed, and traditional approach to outbreak control could not really cope with the high intensity of transmission. What is beginning to emerge, however, radically, beyond Italy, is that countries which were better equipped from a classical epidemiological disease control perspective had the mechanism to surge their capacity to test, isolate, and contact trace and quarantine were definitely better able to manage the epidemic, particularly at the cluster stage. However, among the main factors that explains also the resilience of the health system, as I said before, strong public health leadership and transparent communication to the public that lead also strong public trust were very relevant key factors for successfully cope with the epidemics. COVID-19 has certainly underscored the importance of a tight collaboration between the public health and the clinical healthcare services, especially the primary care. And lastly, among the lessons learned for COVID-19 in Italy has highlighted that health inequities, because persons with pre-existing chronic disease often associated with lower socioeconomic status were more likely to suffer serious complications or die for COVID-19. So I guess that we should now learn lessons from COVID-19 and use this experience to answer questions such as, where should public health service be anchored to be most effective, and how can we build a better public health service And how can we modernize public health service to exploit digital technology in a way that respect privacy and ethics?
Okay. Any of the panelists have any questions for Stefania with regard to Italy in particular? No, not at this moment. Okay, then we go further. Thank you, Stefania. I'll come back to you. Now we go to Professor Servaas More from the Netherlands. In the Netherlands, we have a total amount of corona cases of 52,242, which is quite low, and deaths are 6,139. Recovered data is not given, which is curious, but of course, my question to you is, Netherlands also spiked. However, the country did not become the next epic center. What did the Dutch do differently? Sir, your mic is mute. You have to unmute your mic. Yeah,
I think one of the reasons why it is still limited, although in the last week the number of cases actually doubled, and during this week also the numbers are increasing like in many other European countries, luckily not as extreme in some of those, especially not as comparison to Israel, where the second wave is actually higher than the first wave currently. I think our country is really following the rules rather well, and I think that is the main reason why it is not as extreme as in some other countries currently. But it is worrisome that it is still spiking a little bit and still increasing now for 2 weeks. And I think that in part it is, of course, based on the fact that the rules are a little bit less extreme. The groups coming together are a little bit larger. So it all contributes, for me, a little bit unexpected to a rise in the number of cases.
okay. Then
And I think
yeah, go ahead.
I think the other thing is that we really tone down very slowly. So each few weeks, each month, certain activities were made looser. And if you compare that to Israel, almost everything was immediately allowed again, including large festivals, which are still prohibited in my country. So I think the number of really large risk events are still very low in the Netherlands.
Okay, good to know. So what is, let me put it this way, what is the current status of your country? What policy have the Dutch adopted towards COVID-19?
I think the most important thing is the 1.5 meter distance, which is really very strict. It is in hotels, restaurants. The masks are very strict in a lot of activities, including public transport. And I think all these steps together are the reason why it didn't spike as much as in some of the other countries where it is sometimes a little bit less strict.
Okay. Then one last one I have for you is, are you satisfied with the response of how your government did? If not, what parameters would have you been taken into account?
I think my country actually did it rather well. In the beginning, I thought sometimes it's a little bit extreme, but in the end, it turned out very well. And also currently, I'm happy we do not belong to the countries where there are, again, still a high number of cases reappearing.
Mm-hmm. Okay.
I don't know if there are any things which they have done better. The only thing is that some people, but it's still a discussion, is when and how long you have to wear masks. But apparently, also since there are new scientific proof that there is a potential spread via air, I think it's very wise that especially in public transport and other spots, the masks are mandatory.
Okay. Any of the panelists have any question that what's going on in Netherlands, or shall we move on? Okay, I'll move on then. Now the next is Dr. Patra, Member of Parliament. Coming to you, sir. India has a total amount of corona cases as of today, 1,239,693, with a total deaths of 29,890 and a nice recovery rate of 784,266. However, in the last 24 hours, we have had over 40,000 new cases in the last 24 hours and over 1,200 deaths. This is the first time such a large amount happened in the last 24 hours. My question to you is, today India is ranked third highest amount of cases. Now some are saying we will eventually become #1 at this current trend. A BBC article stated that we could become the next epicenter. In your opinion, how did we get there? Sir, your mic is mute, sir. Yeah, go ahead.
First, I'd like to a warm good afternoon to all my fellow panelists. And thank you, Professor Lal, for inviting me for the panel discussion. India has followed prevention better than cure kind of an approach initially. If you were to look at it, on 24th of March midnight, from then on, it has been a massive lockdown that the country has seen over the last almost 3 to 4 months. And in fits and different times, we have gone through different lock and unlock periods. Having said that, we do understand that India being a vast country and with the challenges that we have in terms of the healthcare sector, it is not possible to have 100% population testing, considering the fact about the expansive 1.3 billion people. Having said that, also the healthcare infrastructure of the country is overwhelmed in terms of the kind of impact that the pandemic has made across the various states. So I would say the country has done well in terms of arresting the spike in the initial period of time. If we were to look at it from the point of April, May, leading up to probably the early part of June, we had kind of tried to flatten the curve to a certain extent. Now, once the unlock 1 happened, that's the point when we started to unlock some of the facilities and then some of the transportation opened up and people could move across from hotspot centers and hotspot states to other states as well. That's probably when the spiking actually happened. So if you were to look at the community transmission versus transmission from people who were from the hotspot zones or in the quarantine zones, even now if you see in India, most of the cases are from quarantine and isolation zones rather than from community transmission per se. Having said that, let me also tell you one thing, that the recent spurt that we're seeing in terms of spikes could be because that right now, that's what, because I'm not a scientist, but I'm looking at it from the policy angle. Most of the signs or the discussions have been that there's going to be a spike towards the end of July and August, which we should taper down by September. That's the understanding that has been given. So that is the flow which is being taking place. Having said that, one heartening factor we can take is that the mortality or the fatality ratios of India is far lower than the global fatality ratios. If you look at the recent data, India has a 2.49% of fatality ratio, whereas globally it's about 4.2%. Now, the second is in terms of testing, we have done roughly about 14 million testing so far. So, and then again in India, what has just happened with the new survey from Delhi, that about 23% of the population is already exposed to the COVID virus. They've done these antigen tests and found out. What I would suggest is India has done well in terms of arresting the increase in the initial days. The challenge right now is to ensure that this spike does not have a continuing trend. Having said that, till now, the healthcare infrastructure of the country, unlike many other Western countries, hasn't really faced tremendous challenges in terms of ICUs or any such. So I would say the isolations, quarantine centers, lockdowns, containment zones, social distancing, usage of masks, all of these have somewhere played an intervention which has been meaningful for India. And we truly hope that that is going to be the case going forward.
Thank you. You already answered part of my second question, so I'll ask the second half. Do you think the actual number of cases are different from the reported cases? Now, why I say that is, for example, Maharashtra is doing the maximum amount of testing, the state of Maharashtra. So they have higher cases. Delhi is doing the second highest amount of testing, so they have the second highest, and so on. UP, my state, we have done only over 11,000 testing, so it's really hard to say. So, and there was a case in Ludhiana, in the state of Haryana, where there was a domestic help who came with complaints of breathing, and she died. And then after testing it, they found out she was COVID positive. So so my question to you: do you think the actual number of cases are different from the reported in India?
You see, in India, one thing that we have seen, again, I'm not talking from the scientific perspective. I'll leave the scientific and the epidemiology part to the experts. But from the policy perspective and the data that we have seen, India is home probably to some of the largest populations of asymptomatic patients rather. And considering that there are asymptomatic patients, and considering in India, a flu or a cold or a cough is considered as a daily routine of life in our parts of the world. So therefore, it becomes very difficult to actually isolate and identify 1.3 billion people based on symptoms. So those are the realities that we have to really go with. But having said that, when you look at, because one of the things, again, I'm going to reiterate, one of the aspects we can take heart from is the fatality ratio. Because every fatality that is being done, there has been a testing that is being conducted at the hospital or at the place, and it shows very clearly that fatality ratios have gone down from 3.4% to 2.49%. But at the same point of time, as you said, there's a large population of asymptomatic patients which are out there. And many a times, many of the states are also coming up and suggesting, instead of overwhelming the health infrastructure, better to go for self-isolation and quarantine and ensure that we are able to lock it at that point of time.
One last one before I go to the next speaker. How, as a politician, what do you think India should have done to avoid the current scenario? We have over 1 million cases. With the asymptomatic, with the lack of testing, there may be, I'm guessing we can be even double, more than 2 million. That is just my personal guess. But what do you as a politician think India should have done differently?
I think we could have stopped international air travel earlier. And for example, we started the experimentation of a lockdown only about March 3rd week, because Odisha, the state from which I represent, we did the lockdown slightly earlier with some districts. But if you look at the nationwide lockdown for a day, came on 22nd of March, and then the real lockdown started from the 25th of March at night 12 o'clock. And secondly, the international travel continued till about 24th of March. I think if we had probably stopped international travel, of course, hindsight is always, a privilege that we cannot always live with. But having said that, when you look at it in hindsight, I believe we could have probably stopped international air travel, because mind you, India was never the home for the COVID as such. It was more, the first phase was when people from abroad with the virus came in. Second phase was when people with the virus moved into their homes, and that was the transmission. And the third phase is when we're actually going towards a community transmission, if at all. So therefore, I would have said, if we had closed international air travel and quarantined people right there when they were landing at the international airports, so we could have been able to arrest the movement of the COVID virus at the point of entry into our country.
Okay, thank you, sir. Any of the panelists have any question for the Indian counterpart? Okay, we'll come back then. Okay, now my next speaker to talk to is Dennis Horgan. Dennis, welcome. Belgium has a total amount of coronavirus cases of 64,627, deaths 9,808, and recovered is 17,347. Belgium apparently has kept it quite low. So my first question to you is, Brussels, Belgium is the capital of the EU. First of all, how is Belgium managing this pandemic?
Well, first I should thank you for organizing this great seminar. It's great to see so many diverse groups of stakeholders, because often it's very scientific, or it's very economic, or it's very one dimension. So I congratulate the university, for bringing 3 continents together, and then also bringing a diverse group of stakeholders, as well as over 1,000 registrants, which is great. On Belgium, Belgium is like, if you look at a state in Delhi or a state in India. India is constituted by 29 states, and Europe is concentrated by 27 member states. So the question is, Europe had a population of 500 million with the 28 member states, which included UK, and now it has around 420. The question often is around what is the public health response in tackling COVID-19, or tackling the symptoms or the disease that leads to COVID-19, because there's often the confusion around what is COVID-19. So the issue there was at a Belgium level, and look at different member states, where Professor Stefanie mentioned at the very beginning, Italy was the first member state of Europe that had a high incidence, and that was because of trading. They had a lot of collaboration and business routes with China, and there was a lot of factories in the Lombardy region, and this had a sense to spread. The question for Brussels and for a European capital is what are the policies to support a public health response? And different countries and different regions, a European region or India region or an American region, had different responses. Now, often they closed down, which was mentioned by one of the speakers, closing down international travel. But a problem with international travel, which Italy was one of the first member states to do that, is probably people could land in Germany and then travel over because it's a different country, so they could travel over. Or if people are coming from different countries on the border by traveling by road, then coming from different regions, then they come and bring the disease. The question was the public health response to this. Now, Belgium didn't do very, very well on this. Of course, it has a good healthcare system, but then it's divided into two regions. So it's very complicated Europe, because Europe competence in healthcare is a national issue. So each state has a role of this issue. And public health often is not funded sufficiently. Often healthcare per se is very reactive. When somebody gets sick, then they go to the hospital or go to the doctor, and then they get treated, and there's a treatment pathway. Often population-based healthcare hasn't been sufficiently funded. And this has been an issue which has been highlighted because of this COVID-19, because it needs more funding, it needs more institutional capacity, how to drive forward healthcare. And often this is not seen as a priority. Often the priority is building infrastructure, such as roads, of focusing on universities, of developing research to drive forward innovation, to drive forward economy. And often the issue around public health wasn't focused on sufficiently. And if you look at different disease areas, such as breast cancer or cervical cancer or cancer issue, then we have population-based healthcare. But often this issue around COVID was an issue around testing. How to identify the burden of the disease in different areas and different regions. But then you have a difficult issue. You need capacity for labs. You need to know, what kind of tests should be done, whether the serological test will work or not work. Then you need to get access to the information. So you need to know, can we utilize this information? Can this information be shared? And how is this information collected, stored, visualized, and presented? Because then you had different methodologies in different countries, because you had different ways of doing it. Even when the European Centre of Disease Control had guidelines and WHO had guidelines, you had different member states having different policies. And this led to this uncoordinated approach. So you have America, they wanted to open very quickly in Americas. They wanted to open very quickly, which now you see a high rise in COVID again. Europe had that clamped down, but now it's opened again because they wanted to support the tourism section. So then you have a rise in COVID, and you have different regions that wanted to open for different ways. So different member states, I highlight this different diversity of approaches because Belgium had a certain approach. If every country in Europe had lockdown at the same time, perhaps this would have stopped COVID. But every member state had a different approach. And because we have free movement of travel in Europe, different people could move around different ways. And as in India, 29 member states, different member states or different areas have different capacities. And this led to this staggered approach where you had a clampdown in certain areas, but then you have people, because people can travel to another country, they can bring the COVID again. And New Zealand is a classic example. New Zealand completely wiped out COVID-19. And then because of international travel, because it's an island separated from every place else, then you had COVID back. So the question is multiple. Is around testing. There's a language issue as well, because everybody in Belgium doesn't speak the same language. And we have many people coming from different countries. Many people may not have access to health services, which may be surprising. And the issue then was around the policy approach. How can we better allocate resources to effectively tackle these issues?
Mm-hmm. Okay, this brings me to my second question, is because Belgium is the capital of the EU. What is the collaborative effort of the EU in dealing with this pandemic? Right now, you've told us about the different member states, the diversity, but when we talk about collaboration, how well was that done in the EU?
Yeah, I would highlight that Brussels is the political capital of the EU. Maybe Rome is the most beautiful capital in the EU, and Berlin could be great for museums. So Brussels is a political capital. It should be highlighted. And of course, Amsterdam, because since we have Professor Sarvas there, Amsterdam is great as well. But I mean, Brussels is the political capital. The issue there is healthcare is not a European competence per se. We just had a big budget decided at the European level. 750 billion euros was allocated to support member states. 7.8 billion euros was supposed to be allocated to healthcare. That has been dramatically reduced to 1.6 billion euros. The issue of healthcare and the response is how can, and the political question, which the politician kindly highlighted earlier, is how can we allocate resources effectively to tackle an issue? And often healthcare is not seen as an issue. Often the economy is seen as more of a pressing issue. How can you drive forward innovation? So Europe recognizes these issues. So it's trying to develop different policy frameworks. A is trying to facilitate cooperation between member states. The one is what you refer to. How can we facilitate more sharing of information between member states? And one of the bigger initiatives they're doing is called the European Health Data Space. And the European Health Data Space is supposed to act as a framework, a mechanism that data can be shared between a federated national databases. So data can be shared in different areas. Then the question is, how can we have more resource capacity between different member states? What are the needs and capacities of different member states to tackle COVID? And what do they actually need? So that's more of a surveillance question, because different member states have more expertise, so different capacities can be shifted from different regions. But Europe didn't do very well at the beginning. It has to be said. I mean, Europe could have helped Italy more, and it was clearly recognized by the European institutions. We could have helped Spain more. But the issue there was now there's a recognition that it needs that as you have organized this global conference here, or seminar, the world is small. So an issue that affects one part of the world, which affected Wuhan, spread throughout the world. The question is, how can we get accurate information? How can we share best practices? How can we share research to drive forward the innovation so we can better treat them? And Europe wants to do this in different ways. I mean, so the issue is, I wish I had a simple answer to your question, but I can answer one answer. The beautiful capital is Rome. The political capital is Brussels. That was my answer.
Yeah. Thank you very much, Dennis. One more thing I wanted to add, why New Zealand eradicated it is because it was led by a woman. That's why they were successful. So that's what people are saying. I think that is the only scientific reason they were so successful. Of course.
In Europe,
it was New Zealand. I was talking about New Zealand. Germany is also doing fairly well, led by a woman, and New Zealand is doing fairly well. So apparently, statistically, women are managing the crisis pretty well than us men. Okay, now I'll go to my next speaker, Miss Rachel England. United States, the coronavirus cases has crossed over 4 million, deaths around 146,000, and recovery is around 1.9 million. Now, my question to you is, when Italy was the epicenter, America's cases were picking up speed. Today, USA is ranked #1 in the total amount of cases, and there are daily new cases, and sometimes it seems that there is no end in sight. What really happened that we reached this scenario?
Sure. Well, good afternoon, everyone, and thank you, Jonathan, for bringing this panel together. It's great to have this conversation with everybody from across the globe. So it's a great question, and I think that we're really having this reflective moment right now here in the US as we look at where we are at this late stage in July, and it's not where I think anybody expected us to be at this point. So whenever we think back to March and what was going on as we were watching Italy and watching the rest of the world, and the government response from the federal government, they started a task force where they brought experts together to talk about what the response should be. And the government decision was to basically let all of the state governments and the local governments decide, what was their response going to be. So there was really no leadership at the federal level in terms of what needs to happen, what should the lockdown be, what is the policy on wearing masks, what is the policy on social distancing, all those sorts of things. So I think that was really, one of the challenges was that we had very little in terms of a federal government response that was very strong, and let, state and local governments, obviously, that did not have the expertise to make decisions based on sometimes more political ideas and concepts than scientific ones. So that's a lot of the problem that we see happening right now. You know, many of the states in the local areas that were hotspots originally, so we look at New York, New Jersey, for instance, where there was a tremendous amount of, you know, burden of disease at the very beginning. They have done a tremendous job in tackling that. So the number of cases that we see now on a daily basis in that area that was originally very, very hard hit are very low now. So, you know, they've done a really good job, and they've maintained a very stringent set of regulations about social distancing, mask wearing, opening up, and even for people who are traveling within the US, if you come from a hotspot area now, they're requiring that you quarantine for 14 days before you move around within even that region. So that's very dramatic compared to what we see in other parts of the US that are now the hotspot. So we look at the South, we look at the Midwest, and even in California, where they had originally had pretty strict requirements for all people. And now they're seeing a resurgence in cases because they opened up early, and now they're seeing these cases start to happen again. So I think a lot of it was really, you know, a very fragmented governmental approach and lack of controlling the messaging about the true urgency about how to prevent against COVID-19, and making sure that everybody was aware of what it was and what the society's responsibility was to keep everybody safe.
Okay. Then a follow-up question on that is, what measures is the USA taking to tackle this problem now? And are you satisfied with that approach? If not, then what should have been done? That's a combo question.
Sure. So again, you know, even to this day, we see that the federal government has maintained their stance that it should really be a state and a local response issue. So, you know, again, it's really been driven by politics as much as science, unfortunately. And a lot of places have seen a negative outcome because of that. So many places that are now experiencing a resurgence had allowed for, you know, very lax restrictions on people gathering and, you know, movement and lax social distancing policies and lax mask wearing policies. So those places, you know, are trying to get it under control. I'm thinking, you know, about Florida and again, Texas are two areas that are really badly hit right now, and other places around the US. But it is the understanding of US citizens who are living here that, you know, many of them still don't believe that COVID is real because they don't know anybody that's had it. There's this denial, even though there are now over 4 million confirmed cases in the US and almost 150,000 deaths. So, you know, the lack of understanding that this is a real thing, that it's not going to just go away on its own, which is something that our president has said on multiple occasions. He actually just started wearing a mask this week in public. Yeah. So, you know, it's really been something where the communication and the messaging from the top down has been so just confusing to so many people that people have decided to believe what they want to believe based on what is convenient for them versus what is scientific, what is proven, you know, and what is the appropriate social response.
Indeed. Thank you very much, Rachel. I'll come back to you again. Now, this closes the first round of general questions, where now the audience has got a feel of how are the different countries responding. We'll go to the second set of questions, which are more specific questions. We'll try to speed through these because we are also running out of time. My first question goes to Stefanie, because you work in the public health sector. They say washing hands for 20 seconds, social distancing in mask will minimize the spread. There are studies on how long the virus can survive on various surfaces. However, there has not been any documented cases of the virus transmitting from any surface, rather human to human transmission. Can the virus really transmit from surfaces?
Thank you, Jonathan. Well, we know that transmission of SARS-CoV-2 occurs through droplets, which are very small particles of saliva. When an infected person coughs, sneezes, or speaks, not only infected persons, also pre-symptomatic, but still infected, okay? Pre-symptomatic or non-symptomatic persons. However, these small particles could settle on surfaces, remain active, because droplets expelled by infected individuals can contaminate the face, and individual can touch the contaminated surface and then with dirty hands touch the mouth, nose, or eyes. However, despite consistent evidence as to SARS-CoV-2 contamination of surface and the survival of the virus, there are no specific reports, as long as I know, which have been directly demonstrated what we call fomite transmission, so from contaminated surfaces. People who are exposed to potentially infectious surfaces often have close contact with the infected person. So this makes it very difficult, you know, the distinction between respiratory droplets and fomite transmission. So it's difficult to discern. However, fomite transmissions is considered a very likely mode of transmission for SARS-CoV-2, given consistent findings about environmental contamination near infected cases. So the fact that also other coronavirus, respiratory virus can transmit this way corroborate this potential source of contamination. So this is why it is necessary to wash hands for 40 seconds after touching any surface. Yeah.
Thank you. Then my second question to you, there was a study in Wuhan, China, that they found the virus suspended in the air at the ICU wards of COVID-19 patients due to possible aerosol suspension mixtures used to sanitize the hospitals. They also saw the highest concentration of the virus at the toilets of the ICU wards, maybe because of the water droplets. And what is your opinion on the aerosol transmission of the virus? In other words, can the virus stay suspended in the air and eventually infect, including using ACs, air conditioners?
Yeah, I give you first a definition. So airborne transmission is defined as the spread of an infection agents caused by dissemination of aerosol, it's not droplets, okay, that remain infectious when suspended in the air over long distance and over the time. So it is still, as long as we know today, unclear whether SARS-CoV-2 could transmitted by this way, because WHO are still discussing, evaluating the evidence published so far, whether SARS-CoV-2 can be transmitted through air, through aerosol, not to droplets. However, about possible mechanism of SARS-CoV-2 transmission through aerosol, the theory suggests that a number of respiratory droplets can generate microscopic aerosol, so below 5 micrometers, by evaporating, and normal breathing and talking also results in exhaled aerosols. So in this way, a susceptible person could inhalate aerosol becoming infected if the aerosol contained virus in sufficient quantity to cause infection. However, the proportion of exhaled droplet nuclei or respiratory droplets that evaporate to generate aerosols and also the infection dose of viable SARS-CoV-2 required to cause infection in another person are still not known. However, very recent publication in clinical infectious disease of the past week have demonstrated that the virus are released during exhalation, during talking and coughing, in micro droplets small enough to remain a lot, in the air and pose a risk of exposure. However, WHO so far not yet, reported a clear evidence about that. Because many studies, however, conducted so far on the spread of other viruses, including other kind of respiratory virus, also MERS and influenza, show that viable airborne particles can definitely be exhaled and or detected in the indoor environments. Anyway, so we have to see, to give a final word on that. Considering, however, air conditioner system, I want to just stress the importance to remind that the transmission of COVID-19 commonly occurs in closed and crowded indoor spaces, independently of air conditioner systems. However, that air conditioning system with the recirculating system in closed environments should be avoided. Okay, so recirculation of air conditioning, this is something that has been acknowledged by WHO, that should be definitely be avoided.
Okay, I'm sitting in air conditioning, but there's nobody sitting with me. I think I'm pretty much safe that way. Stefanie,
no problem.
Yeah, my last specific question for you. You were at the forefront of the fight against the virus. What was your role towards this? Please share some of your experiences.
Yeah, I work in the Department of Public Health of Catholic University, where is also based Professor Walter Ricciardi, who is my colleague. I work with Walter Ricciardi since more than 18 years, and he is the counselor of the Prime Minister of Health, coordinating also the Italian task force supporting the Ministry of Health. So I do collaborate with Walter Ricciardi in supporting and giving advice to the Ministry of Health in this epidemic phase.
Okay. Thank you very much, Stefanie. Now I go to Netherlands, Servaas. My first question to you, what do you think of pooling of samples to reduce costs and increase speed of testing? Is that a go or no go? But could you first tell what is pooling of samples for the audience?
Thank you very much, Jonathan. The pooling of samples means usually you take 10 or 20 or 30 samples together as one sample and generate one test result. This will save a lot of money. It will save a lot of time. It will save scarce ingredients for PCRs and swabs. If you do this for epidemiological studies, it is of course always okay. If you want to have in a new city like you did in New Delhi in India, like they did in Wuhan, screening whole cities to see where are the biggest sources of new spread, it's a good approach. However, if you use it for other approaches, for instance, in the situation where you want to know if people have COVID and enter a plane, because in many countries currently, in the Netherlands, in Europe, in USA, before you enter a country, you need to have a certificate that you have no PCR positive result before you board a plane. If you do it then, and you pool 10 people, it means you lose sensitivity of your assay. It's a complex story, but let's say that normal positive cases are between 13 and 40, and that the weak positive cases are between 35 and 40. Pooling by 10, it means you lose 3.2 CP value. So someone from 36.8 will be 40 and negative. Then you have two teams. One team could say, well, these are people who have a very low load. They will not spread. They're most likely at the end of their infection and it is some dead material and it is highly unlikely they spread. However, it could also be that it are people who are just having the infection. And some countries ask a PCR 3 days ahead, some 2, and some even 7 days. So there is new time to develop. One of the companies I advise in the last weeks, when we do corona PCRs for travelers, we saw a lot of these weak cases between 35 and 40. This week, however, the number of cases going up between 26 and 32, meaning a lot of the weak cases can actually be cases which are emerging again, which is also supported by the new rise in cases in the Netherlands and also in other countries. So if you do this for planes where you expect upfront asymptomatic people with low titers, I would not advise to pool personally. Mm-hmm. If you have scarce materials and you would like to pool in a setting where you only have symptomatic cases and want to be speedy and you expect COVID with CP values between 16 and 26, 27, if you pool by 10, those cases will be 31, 32 max. So you will not miss cases of the symptomatic severe cases, but you will still miss cases with low viral loads from which you do not know if they are clearing or just upcoming. So it's a little bit of a balance. But for my point of view, for doing it for airplanes giving certificates, I would not advise it.
Okay, good to know. Then my second question to you is, are there commercial opportunities for corona testing? We're seeing a lot of this going on. And since you're also in the work of business, we would like to hear your comments on that.
Yes, like I said, I'm only an advisor of those businesses. I'm not the director or a manager in any of them. What we see in the Netherlands, there are both a lot of companies arising which provide serology to people. That is not a diagnostic test by law in our country, but that can be different in different countries. We are not allowed to provide a throat swab to a direct-to-consumer approach because it's not taken by a clinician. That can only be done in a clinical setting. If I look to our country, I think there are around 8 companies who offer serology to clients which they can order by internet. And what is currently happening, there are a lot of companies who arise currently to do testing for travelers. And like I said, with the pooling, there are different strategies used, which is sometimes a complex discussion also for the law enforcement, because some of the poolings, the question is if that is really wise. Mm-hmm. We actually also explored testing in India on a more commercial way, but your government kind of fixates the price, which is so low that from a commercial opportunity in your country, it's very complex. And also the regulations in different EU countries, they're all different. So it makes it very delicate because the fees by the controls in every country, if you do something which is not accorded by law, they are very fierce. So there are opportunities, but you have to be very well informed what is allowed and what is not allowed. And I think especially for PCR, I agree with my country's attitude that you should not do that in a direct-to-consumer and offer it to clients via internet, because you will get unreliable results.
True, true. Okay, then my next question for you is a bit different. They say vaccine development is the gold standard. They say vaccine development gold standard is 18 months. We all know that minimum. And from drug discovery, a minimum of 5 years. We are now hearing in the news fast-track vaccine development and repurposed drugs. Now coming to vaccines, how can vaccine development be justifiably fast-tracked to a few months given all the clinical trials and testing of the population? In other words, if a vaccine comes out very quickly, would you take it or would you wait for it to be tested on the rest of the population first?
That's a tricky question.
Hello? Yeah.
It's a tricky question. First of all, the first vaccines, the first results are already there, and the complications are already shown, which are like headaches and a little bit of fever, just the normal things. Personally, but it is my personal opinion, I think that the vaccine normal times are that long because you would like to have some information about long-term complications. And the long-term complications cannot be assessed in such a short time. Hence the reason why a lot of people have their doubts. On the other hand, it is such a severe infection, it has spread so extremely quickly that a lot of policymakers, of course, say, well, there are circumstances where we have to deviate from the normal regulations and consider quicker implementations. And that, again, is a very difficult balance to choose from. Personally, I think some of the vaccines developed in the past had some severe complications in the long run. So, like I said, it's a very difficult balance currently.
Okay, thank you very much. Now I go to Dr. Patra. Can you hear me, sir? Dr. Patra, can you hear me?
Yeah, I can hear you. Yes.
Okay. So I have a few quick questions from you. I understand you come from the state of Odisha in India. Your party is in power in that state. What has been the plan of your government, and honest have you been, and where were the shortcomings?
Well, I believe Odisha has been far blessed and probably far. Am I audible?
Yeah, you are audible. Go ahead.
Okay. So if you look at Odisha, Odisha has is a state which is one of the lowest fatality ratios in the country. It is a state which has got more than the better recovery rates in the country. in terms of sample multiples and testing also, when you were to look at it, it is definitely doing much, much better than the rest of the country in terms of not only testing, isolation, quarantine. You'd be happy to know that more than 700,000 people have been quarantined in Odisha over the last almost 1.5 months. But Odisha was the first state in the country to actually come up with COVID standalone hospitals way back in end March 2020. So therefore, even before Odisha, the state of Odisha had about a handful of COVID patients. The state government, led by Honorable Chief Minister Shri Naveen Patnaik ji, has been extremely proactive in terms of ramping up capacities. And presently, we have more than 600,000 beds for COVID standalone hospitals primarily. Now, when I say COVID standalone, many of the hospitals in the country, each a floor or a ward of that hospital has been transformed into a COVID ward or a COVID region as such. But in Odisha, and of course, in many states now, you also have standalone COVID hospitals, which ensures that the protocols and the sanitization is maintained, considering the probability of this virus. So Odisha has been doing far better. But of course, of late in the last 2 days, we have seen a spike of about 1,000 cases, which is worrying. But I'm pretty sure that the way things are being held very, very strongly together, not only in terms of ensuring isolation and quarantine, but also in ramping up testing, as well as ensuring ready interventions within the hospitalization process. Odisha has one of the lowest fatality ratios in the country. So in that way, but having said that, still a lot needs to be done, and the government on a daily basis has been working strongly in terms of enhancing and ensuring also the protection of the COVID warriors, the people who are actually on the front line, working in the hospitals as nurses, doctors, paramedics, police personnel. So for all of them also regular protection. So I think Odisha state has been doing fairly well.
Okay. I think if we've already talked about the testing, so I'm not going to that. Why does the government say that we are not yet reached the stage of community transmission? ICMR, the Indian Council of Medical Research, says we are not in community transmission. But if we're number 3 in the world in the total amount of cases, and we are having jumps and spikes every day, and there is no more foreign travel, why, in your point of view as a politician, do you think the government is saying that we do not have community transmission?
You see, the transmissions that we have seen in India so far have been transmissions from people who were from hotspot districts who came in. Let's say, for example, the state of Odisha. We had about 700,000 people who were from Odisha working in other states of the country. Once the unlock process started, the lockdown was eased. They moved into Odisha. They're kept in isolation and quarantine zones. And what we really see today, most of the cases that are appearing are from these quarantine centers, from people who were from these hotspot zones. Now, if these people had actually moved into the villages, and in the villages, they had actually come in contact with the local population, and thereafter the community transmission has spread, then probably we could have said that we are at that stage where we have moved to community transmission. Though I'm not privy to all the data and information of ICMR, I would say that at least in Odisha as a state, because I'm actively involved with the governance process here, considering the fact that our government is in power, we have been seeing that community transmission has not really spread. Rather, people who were infected. Now, the idea is that since there is no foreign travel, can we say that community transmission therefore has started? Well, the question is that it's a first-hand basis, or it's a second-hand basis, or it's a third-hand basis. At what level are we in India? I would still say that people, because of the long, gestation period, if I can use this term, because initially the government said it'll be 14 days, then they extended to 21 days, and then it came down to 28 days. I think the main crux, the issue right now is the large population of asymptomatic patients. I think this is something, you've got a very distinguished panel of experts from the scientific field from public health. India could be one of the best case studies in the world when things get better, to actually see that if a study from Delhi comes out, New Delhi, and says that 23% of the population has already been exposed to the COVID virus, that itself shows that there is a large population of asymptomatic people who show no symptoms and are still prevalent within the society. Plus the ICMR guidelines. I'd just like to touch on the testing part. The Indian Council of Medical Research, which is the nodal body for all testing activities per se, they have clearly stated in their guidelines that testing needs to be only done for symptomatic people, primarily because the testing requirements as such in this country is already at an all-time high, considering that we were never prepared for something like at such a big level. But having said that, I believe that asymptomatic patients somewhere and their prevalence in the society is something that is not viewed by us. Having said that, I still believe that we are not into the community transmission phase.
Yeah. Okay, we're running out of time. One very brief answer I would like from you. Amidst the gloom in India, are there any silver linings also? If so, what? Can you tell us something about it? But very brief if possible, sir.
The silver lining I would definitely, again, reiterate, which I've already reiterated twice, is the fatality ratio. So considering the fact, again, the jury is out on the fatality ratio because comorbidities and people who are passing away because of comorbidities, is it because of that or is it because of COVID, or did COVID really, trigger those comorbidities to a terminal level? I think that discussion will always carry. But if you look at the facts that have been placed by the different states and the union government, the silver lining is the fatality ratios have in fact reduced from the global 4.2%. We were at 3.4%. Now we have gone down to 2.49%. I think that's the silver lining. Plus the fact that in many places like Delhi, you're actually seeing a decline. So therefore, there are also spots and states which are showing a decline already. They had spiked much quicker, and they're now coming down on the flattening of the curve. States like Odisha also would be bucking the curve, hopefully. And so I think we are on the right track. We have to ensure that the social distancing and other norms sustain.
Thank you very much, sir. I go to Dennis now. You represent an organization cross-cutting across the European Union, the European Alliance for Personalized Medicine. What has been the role of the EU APM, the European Alliance for Personalized Medicine, during this pandemic? What policies and action plans have been brought forth by EU APM to influence members of European parliaments and policymakers across the EU on COVID-19?
Yeah, I mean, COVID-19 has been, a critical juncture to highlight the need for a more public health response. So this, a lot of public health policies has been put forward over the years. It's not like it has not been presented. It's not like the research has not been developed, but often the political will was not there to bring this into healthcare systems. And that has been the big change, I would say, that can be a driver to improve healthcare in terms of population-based healthcare. Of course, testing and diagnosis for different diseases has been a big issue. When we look to cancer, for example, 1 in 3 people globally will get cancer, but often this has been a late diagnosis issue or a treatment issue, or how do we have a better understanding of the disease in terms of translation research. COVID has acted as a critical point to add more momentum there. So in this point, what we've highlighted is what kind of from a policy perspective can be done. So we've highlighted that there should be better testing. There should be better testing across all disease areas, not only with COVID. COVID is one example of one type of test, but it needs to be early screening, early diagnostic tests, better use of diagnostic and biomarker testing, and better use of advanced molecular diagnostic testing. This is one area that we put forward. And now Europe is developing this European Beating Cancer Plan, and that should come out at the end of 2020, which of course they have developed another area, developed cancer missions, which Professor Walter Ricciardi, Professor Stefanie Bosia mentioned. He took a lead there, and now they're developing a cancer plan. So this is one key area that will give a lot of input around these areas. And then how can systems be better joined together to support collective action? And a lot of these issues is built around how can we have better access to data, so then developing the public health response. So now there's more recognition that there needs to be more sharing of expertise, but the question is, what is the infrastructure to do that? So then we say, how can now, looking at the different mechanisms that Europe is putting in place, different funding streams that are put there, how can these be really tailored for the public health perspective, which is often overlooked. Often is seen that population-based healthcare and personalized medicine, because you're focusing on the individual, is contradictory. But in fact, if you can't identify the patient in the population, then you can't be personalized. So in a sense, you need a common approach, you need a systematic approach. So the different areas that we're not asking to reinvent the wheel, we're asking to concentrate the collaboration that's being done in different regions already. And then the area is to keep the momentum on public health. So then you can drive systems around, because the issue all across healthcare is a population-based issue. And the question is, how do you improve early diagnosis? And then how can you improve quality of life? And that's just getting healthcare systems to be more modernized so they can utilize better technologies in a more effective way. So we've worked with the different institutions at the European level, as well as different member states around this to see how can we improve cooperation and different collaborative frameworks.
Okay. Just one more question for you. I understand your organization works with big pharma. That is, a lot of pharmaceutical industries are collaborating or are part of your member of your organization. Generally speaking, what is the progress so far in vaccine development and drug development against COVID-19 in the EU?
I mean, it's very hard for me to answer this question, because although I have a PhD, I'm not a scientist, and obviously these are very specialized areas. So every pharmaceutical company is trying to develop, or collaborations of scientific or pharmaceutical companies are trying to develop. The question is, you have to see the scientific data. 2 studies have come out that are quite recognized. The Oxford study done by John Bell, and where AstraZeneca has done a public partnership with them, and then a Chinese study which has shown some promise. Of course, other companies have highlighted, but the question is not per se the vaccine that will take time to develop. They have to ensure the safety of this. So I think Europe has a critical role here, because it has very high safety standards and efficacy standards. So this is a key crucial question. But then the question is, how can this vaccine be given to the world? So it's a common good or public good. And this has been one of what European leaders have highlighted. I think the vaccine will be developed. The question is, will be a time issue. But the question is, it needs to be given and ensured that it has a global access. And that's what Europe is really focused on, which we have tried to do. Because of course, you don't want to keep in one country and then say, like, cost of treatments, like in US are dramatically higher for different types of interventions or different types of treatments. If you look at diabetes treatments, they're very, very expensive. So the question is how to ensure equal access. And Europe is investing in this, America is investing in this, China is investing in this, India is investing in this, so all about this. But the question is, I would say, from a global perspective, because this is a global issue, how can we ensure global access?
Thank you, Dennis. Okay, back to the USA. I'm sorry we're running out of time, but I want everybody to have equal amount of time. Rachel, social distancing has been of uttermost importance. I understand not all doctors are getting the proper personalized protective equipment, and people, including doctors, are scared to treat COVID-19 patients. I understand you in particular work with hospitals to use virtual care technologies toward this end. Could you elaborate on that?
Sure, absolutely. So definitely at the beginning of the outbreak, we saw a tremendous amount of logistical challenges with many of the hospitals getting the types of PPE that were required for the healthcare providers. And this really just highlighted many issues, that face our healthcare system as a whole, and particular hospital systems specifically. One thing that many hospitals ended up doing as a response was that they shut their doors essentially to a lot of the types of patients that maybe would go in for a normal type of office visit, or they would go to the emergency department for something that was potentially not really life-threatening, and shifted very, very quickly to the adoption of telemedicine and telehealth type of services, where leveraging if you had a telephone or a cell phone or your computer that had video, they would use that, or if not, even just your telephone, to have a conversation with the patient and to triage and address a lot of their concerns remotely, so that the patient never had to leave their home and potentially be exposed. This was also a great way to save a lot of that PPE that otherwise would have been necessary to use for every single patient that was walking in the door. So yeah, we've seen a tremendous amount of the expansion of telemedicine to treat those types of things that were not, immediately life-threatening for the patients. And now as we talk to organizations, healthcare systems all over the country through the work that I do, we're seeing that the interest is really in how do we use this opportunity where people's minds have changed about the adoption of telemedicine and telehealth as a way to receive healthcare services and really leverage that and take that to the next level so that we can continue to use telemedicine, telehealth, and other types of virtual care services to reach patients in their home where they're most comfortable and they're most safe during this time of outbreak and for the future. We think that it's also the way that we're going to be able to expand access to lots of patients that typically wouldn't be able to get access any other way because of logistical challenges, not being able to get transportation, what have you. There's a lot of different technologies out there now with remote patient monitoring, with the types of devices that can easily be sent to the patient where they're monitoring their vital signs and can be hooked up to alerts that are monitored by providers in a common area, so that that data is available and can be acted upon in a way that is timely and efficient for the providers as well as the patients.
Okay, that is quite interesting. I think a lot of different countries can take use of that. I had another question for you. The current healthcare setup of the USA, for example, in the EU, it is a socialist approach, whereas in America, being capitalist, does not have a mandatory health insurance. How does that play out with regard to COVID-19 treatment there?
Yeah, absolutely. It's been a very interesting type of situation going on here with COVID because the federal government, in some of their response that they did do, they acted very, very quickly to say that, whether it's testing or specific treatments for COVID-related issues, you're right that we don't have any type of, standard across the board health insurance or guaranteed access to healthcare. However, for COVID specific types of treatment, that it would be covered and that patients wouldn't be charged for it. So, that was one thing that the government did do to alleviate some of those concerns about access to treatment for COVID related issues. That said, because of the capitalist way that we treat patients and that we have for accessing care here in the US, there has been a lot of concern amongst the general population. Obviously, COVID has had a dramatic impact on our economy in this country as well as around the world. And many, many people who would typically get their health insurance through their employer, when they were laid off or furloughed, they lost their healthcare coverage. So that's another big challenge that we're facing now and will continue to face while we're in this period of high unemployment, where many people that otherwise would have had health insurance through their employer are not covered at all right now. So, while the government is saying we're going to take care of issues related to COVID, any other type of condition or issue that may arise that a patient may have, they don't have the health insurance to help them take care of those issues, which is definitely a challenge.
Indeed. One last question for you. We are seeing an incredible amount of innovation and creativity from a variety of businesses right now as things are rapidly evolving. What are the opportunities for the future that will have their origin in this time of challenge, a sort of silver lining as well?
Absolutely. Yeah, I think that this is definitely something that we can take away from this as, a positive in this time that is so difficult for so many people, is that, we have seen creativity really kick into overdrive here in this country as well as around the world in terms of how do we approach treating patients differently and leveraging technologies that typically we might not have thought of in the past to access patients and get them access to care and to help to address some of the very ingrained type of challenges that our society face around equity of access to healthcare services. So how are we thinking about the entire population and making sure that they have access to not just emergent types of issues, but routine care as well? So I think that there is definitely a different way of thinking now from, the general population, as well as the government and the leadership of the health systems and hospitals all over this country, and thinking through how do we change the way that we've done what we did in the past to accommodate for, this expanded set of patients and community members, and thinking about things a little bit differently. So I think there is the silver lining in that, there is this new period of time where people have a different thought process and an open mind to trying something new, and they're willing to make investments that they otherwise probably wouldn't have.
Thank you very much, Rachel. Okay, this ends round 2, and I think we are way over time. It was a 1-hour webinar, but this is our first time we conduct something. I have not seen this anywhere else in the world. I think we are the first innovators actually doing it. One of the panelists, Dennis, had to leave for his next meeting. The third round is the Q&A from the audience. Before I proceed, I want to ask the current panel members, can they spare 5-10 minutes to do this part, or shall we close? Although we are running out of time. I understand Sarvas is also quite busy. He has to go. Maybe 1 or 2 questions we can take from the audience. 1 or 2 questions should be okay. So one of the panelists is asking, in India, we are given vaccinations at a very young age. Is this the reason the death rate in India is low as compared with other countries? This is an open-ended question. Anybody can answer this. He's just asking, is that a case? Is that the case?
You see, honestly, though I'm from India, I would not have any scientific background or any scientific evidence to say that. And honestly, I don't think at the moment, I mean, of course, the experts are here, they can add, but it would be very difficult to correlate an evidence to say that, yes, COVID, because we've had inoculations and vaccinations during, right down from the childbirth till about the age of 10, would that really have impacted our immune system? I can definitely say Indians are very immune to a lot of things, because we are so immune because of so many typhoid, measles, chicken pox. I have suffered all of it already. So because, we go through phases of so many diseases in our life, I don't know whether that impacts. Of course, that will be for future studies and interesting studies. But my guess, again, it's a guess, it's very too early to call that.
Okay. Anybody else wants to comment on that, or shall we go to the next question? Okay, next. This one is for Sarvas. The audience has asked. A BBC News article claims that blood samples collected between 2015 and 18 show T cells against COVID-19. They want to know your views on that. Unmute, please.
That's a complicated one. It's not completely my field of expertise, but it is clear that having antibodies, it gives some kind of protection, but it's also very clear that people who have COVID infection proven by PCR have no antibodies anymore. They still can combat the infection by T cells. So the question is a little bit what they are recognizing. So I can imagine that there is a possibility that there are immune pathways which will actually have an effect on certain viruses, because our whole immune system is primed, for instance, with all kinds of receptors like tolls and knots who recognize bacterial and other components for the innate immune system, that there might be general immune systems which already can combat an infection which we deem as relatively new.
Okay, thank you. Okay, I think now we have run out of time quite a lot. We're like half an hour over. First of all, before I hand over to Professor Viru Prakash, I apologize to the participants that we could not get up your questions, because this was the first time we did such a unique panel discussion, which has never happened before. So this is something new for all of us. I would like to thank our panelists. Thank you, Sarvas. Thank you, Dr. Patra. Thank you, Stefanie. I really appreciate it. And thank you, Rachel. I mean, it's like super early morning at your place, and you were so kind and accommodating to wake up so early around 4 a.m. and join us for this panel discussion. Thank you very much. And I also thank Dennis. He had to leave for another meeting. I really appreciate his input. And with this, I will now hand over to Professor Viru Prakash for the closing.
Thank you, sir. Now, as the webinar is coming to an end, I take this opportunity to invite Professor Robina Lawrence, Associate Dean Academics, JIBB, to propose the vote of thanks. Professor Lawrence.
Thank you, sir. It has indeed been a very interesting and informative session. On behalf of JIBB Institute of Biotechnology and Bioengineering, Sam Higginbotham University of Agriculture, Technology and Sciences, Prayagraj, I would like to express a sincere thanks to our esteemed panelists, Professor Sarwas Moray, Professor Stefanie, Dr. Saswat Patra, Dr. Dennis Horgan, and Ms. Rachel England, for sharing their expertise and discussing the various aspects of COVID-19. I gratefully acknowledge the efforts of Professor Dr. Jonathan A. Lalser, Dean, JIBB Institute of Biotechnology and Bioengineering, and Director, IPC, for organizing this very important event. I also thank my colleague, Professor Prayagraj, Associate Dean of the Institute, for his support and cooperation. Sincere thanks to Engineer C.J. Wesley, Joint Registrar, Administration, and Chairman, Social Media Committee, SHUATS, for providing the technical and logistic support. Finally, I express my sincere thanks to all the participants for their overwhelming response. Participants can download their certificates by clicking on the link displayed, www.shuats.edu.n/panel discussion certificate. You will also receive an email from the moderator with the link to download the certificate. Thank you, everyone, for joining us. Have a nice day.
Thank you so much.
Thank you, ma'am. Now I declare the webinar closed.
Thank you.
On behalf of Sam Higginbotham University of Agriculture, Technology, Sciences, Jai Yeshu, Jai Hind, Jai Bharat.
Have a good day, guys. Bye-bye.
Thank you.
Bye-bye. Thank you very much, Jonathan. Excellent job today.
Thank you, sir.
Thank you so much, everyone.
Bye-bye. Bye-bye, Rachel. Bye-bye, Dr. Patra.
Bye-bye, everyone.